get started and then we'll go from there.
Okay. Yeah. Thank you. Well, I know it's coming to the end of the day, so I'm going to try and keep you going just to the last little knockings. So it feels slightly weird for me. My name is Nick Butterworth. I'm the chair of the Society of Musculoskeletal Medicine, or SOMM. And it feels weird because traditionally the MACP and SOMM have always been sort of poles apart. You've either gone one way or you've gone the other. So actually being invited to come and speak to me is probably quite a momentous occasion. It feels like I shouldn't really be here. So I think really this really stemmed from conversations of myself and Neil around about kind of a year ago. And so, I know that obviously 2025 is the year where, probably middle-aged people who should know better, it's not all about the Oasis reunion, it's not for that. But what we're really trying to encourage is actually the fact that we're just collaborating together as the MACP and SOMM. Now traditionally, and a lot of people will feel, obviously here in the room, you're MACP people, and invariably a lot of people, there were comments earlier on about you tended to follow what your supervisor had said, or your boss, or whoever it was that was leading. If they were an MACP person, you tended to be put on those courses or funded. If you were a SOMM person, you kind of went down that pathway. Now realistically, a lot of these things and these discussions were things that went on years and years ago. Obviously looking at how young and lovely you are in the room, it was way before all of you were born. But the idea really is what we're trying to do is saying, well, we're all trying to do the same thing. We're all trying to make public health better. We're all working in the MSK space. So rather than it being that you have to be one or the other, what's wrong with being both? What's wrong with having more tools in your toolkit to choose what's right and what's wrong? Now also with this, I think, again, if you've been an MACP person, and some people are quite, vehement on that line, just the same as it is at SOMM, so it's not one or the other. But what you then try and do is quite negative about the other group, and that's not always helpful. And what I would like to try and do is challenge, in terms of the, the challenging concepts was the title of or the theme of the day, and I'd like to try and challenge some of the thoughts of what's going on. Now, what I would say with that is I think it probably kind of gets an idea of where we started from, and where I would say some of the criticism SOMM's had over the time is pretty reasonable. So this is I've just got a little quick video of James Syriac, who was the kind of godfather of MSK stuff, which is the kind of stuff nowadays you'll be going, oh my God. But this is really where we started. So let's just see that it works okay.
And in order to do that, you need two assistants, one at each end. And the patient's bones don't come apart. I let them pull for a couple of seconds. Put your head down. Put your head down. I put one hand on the most painful spot and twist my hand so that the fifth metacarpal bone is up against the spinous process. I then press with the other hand, straighten my elbows, and bend my chest forwards. Not really.
So you can kind of see a little bit. Do you want to see that again? Yes or no? If it's a video nasty, no one wants to see it again. But it's all of those same sort of things. I mean, we've sort of rediscovered these old videos. We've got like what wasn't a podcast, it was like an interview thing. So we've got some of these things, and it's quite weird to sort of look back on with your eyes today. But that's where it all started from. And I guess the one thing that happens is if people have continually said that's what we do, it's understandable why people are going, hang on a second, I want nothing to do with this. So, what I would say is that what we're trying to do is we've tried to evolve what we're doing, but respecting where this started from. And the idea is now that we're all doing similar things. Now, the two people on the screen there, on the left-hand side is Monica Kesson, and on the right-hand side is Elaine Atkins. Monica, sadly, is no longer with us. Elaine is actually our president, so she's been around in the society, and it's been around sort of 45, 50 years. And just even something recently, understanding that the books originally, they wrote the first sort of manual, and the books were green, and it was very weird that they worked with Syriacs in St Thomas's Hospital, and the woman on the right of the video was Patsy, his wife, and that kind of taking his jacket off was how it was all done. Now, obviously, we don't do that, but there was a big sort of group of people where they kind of, that was how they started. And what Monica and Elaine did was take that principle and start to modernise it. So that was the first edition of the book. But also with that, it's evolved over the years. Now, even, you know, this is something, and again, it's done light-heartedly before anyone gets too offended on it. This was the job at the advert for the course that was in Frontline at the beginning of the week. Now, it actually said about the Society of Orthopaedic Medicine, and we've changed that, and we've been Society of Musculoskeletal Medicine since 2013. So you see, even with people where we're all together in the room, it's thinking back to that orthopaedic basis. You know, luckily and hopefully we've changed our view on things and the way we do things. But the idea really is just saying, actually, you as MACP and the learning that you do in terms of your masters isn't too different. We might have slightly different ways of going about it, but the principles of what we're doing is all the same. There's a lot of things to share. And so just some of those kind of things. Again, these are old photos. So actually these would have been green trousers with green t-shirts and stuff like that. But that kind of collective of almost having a group of physios that did what they were told and that they followed a pathway, that is how it was. You know, but now we're on to the 5th edition of the manual. And all of those types of things that we've been talking about today, where where Roger's been talking about how it's not about a joint moving and mobilising, it's more about creating movement. Those are concepts we've been doing. It's quite nice to have it kind of reaffirmed on an academic level. But the idea is all of the communication skills that that David's been saying, things like that. We've been changing that, and probably what's happened is because you've been MACP, the fingers have been in the ears, and actually on the other way, when we're SOMM, we're doing that when the MACP say something. But the point is, we're all trying to do these things. You might recognise someone in here, so the second person in is Sharon Chan-Barrett. She's involved now with the MACP on the exec committee and is part of doing the portfolio route. So again, we're starting to sort of understand and work with each other, and part of this collaboration is it's an opportunity for people, for example, if you're not a member of the MACP and you're thinking of it, to do the portfolio route, where some of the courses that we run in SOMM now would qualify and sort of tick a certain box to be able to work and go towards the portfolio route. So the idea is we've been evolving over time, and then from this point of thing, that kind of thing, if you will, always sort of gone, well, I'm not really into SOMM because I'm with MACP. Well, isn't it just frictioning? Isn't it just frictioning and injections? And that's kind of all you do. And some manipulations, and oh my God, they still do cervical spine manips, and all that type of thing. Well, the idea is, that's Johnny. Johnny's our chair of education with Ruth, one of our tutors. He even removed his own jacket. That's how far we've come. That's how far we've come. So, but the idea being is the fact that, we've moved on from that biomedical model. The original Syriacs of there is a lesion, you do this, it gets better, and you can see by the way that he was talking to the model. Put your head down. Put your head down. There's no please or thank you. So the idea is that obviously the biopsychosocial model, which is what we all embrace nowadays, and that understanding of what goes on, that's really where we are. So we've moved away from that, but again, it's still that's the sort of thing that keeps being labelled to us. You're still doing the same thing. The other sides of that, a few years ago, everyone had a traction bed, and then it started to just gather dust, and people didn't bother doing it. And there was a great place just to store stuff, mechanical traction. And those other days, again, I can remember, and I don't know whether some people can, of having endless lines of people with weights around the neck for mechanical traction for cervical spines. Luckily, I haven't seen that in years. I'm not saying it doesn't happen, but luckily I've not seen it in years. So all of that kind of thing has disappeared. And then we always kind of evolve treatments. So, we had a big debate about whether we keep in things like, do we keep in frictions, do we keep in manipulations, and we change techniques. And particularly, I'm part of the injection therapy team, and we talk about which injections we should do and shouldn't do. So there is a kind of an evolution, and I think for me, I'm very conscious that we don't remove too many things because it goes out of fashion, because then there's skills that might get lost. So I'm not suggesting that, for example, cervical manipulation is exactly what you should do, but I'm not saying it doesn't have a place at some point in the right time and the right circumstances. And if that's a skill we lose, then we can't then teach the next generation of physios. So again, I think things like this is important. And I think one of the skills that I feel that SOMM would be able to give towards the MACP members is we were the first sort of recognised injection therapy course. There's obviously loads of universities doing courses now. We're not saying we're the best, we're just saying we've been around a long time. We have a lot of expertise between the teaching team plus those clinicians who've gone through. So the idea is we're at the forefront of that and being able to understand with prescribing. I know Helen Welsh is in the room and she's doing a study with Sharon about doing kind of competency frameworks for injection therapy. You know, how many injections you should do per year to maintain competency. So there's things that are going on that are being evolved, and we're being part of that to try and being able to understand what's safe practice. And then realistically with that, the one thing I don't want to do is ignore where the past. Now, we don't do what Sirius has done in the video, luckily. But the idea is those principles of treatment, or principles particularly of assessment, are still useful. Now, a lot of the conversations, I'm a private practitioner, but I hear a lot of the conversations that's gone on today about FCP, about time, and about that kind of, you're limited with what you can do. I still strongly believe that kind of Syriacs or SOMM principles of assessment is a really, really good, quick way of getting towards a diagnosis. Now, I'm also an advocate of not the diagnosis isn't the most important thing, but getting towards being how you use things. The diagnosis for me, the assessment and the treatment, the principles are still the same, and then you add to it with all of your other experience. So I still think that has a place. I think also with that, again, we've moved away from being too specific. It used to always be about disc bulges and things like that. We're now about medical models, so sort of a group of patients that you might choose these treatments for. So again, we've tried to hopefully reflect some of the stuff that Roger was saying earlier on. So what are we up to now? We still run the foundation modules, which used to be the diploma. You know, we've changed from being A, B, C, so A is cervical spine and upper limb, B, lumbar spine and lower limb, and then C, everything else. We've completely changed. It's now 1, 2, 3. It's totally different. But the idea being really is the fact that, you know, it still sort of goes on that basis. The foundation still offers master's level credits. We used to run a master's course, and eventually we found that it doesn't really work for us financially, so we moved on. We run the injection therapy course on a regular basis, so we tend to be, our HQ is in Liverpool, but again, we will run them all over the country. As we said, that Sharon's mapped it to the MAC portfolio route, so again, to be able to get credits to become an MACP member, and again, leaves the opportunity to share ideas. We're mapped to IPOM standards, and like we say, we give master's level credits for the courses we do. And the idea really for that now is to show that, you know, we have the kind of academic rigor and credibility within the space, but it's also looking about evolving things that what do people want. There we go. So the QR code just takes you to the SOMM website if you haven't already known or whatever. So the other side of that, of what we're doing now, the skills exchange events, we work and we've helped out with Physio First previously, Katie's at the back there, to be able to try and support different people in terms of whether they're students or whether they're qualified or using the experience. There's an injection therapy update day, so if you are someone who's injecting in practice, to be able to kind of get an idea of what current thinking is, or sometimes you do your course and then you won't work for a few years and not sure what happens. And then really another thing is a spinal manual therapy masterclass day. That's a new product that's coming on a little bit later on in the year. But what I would say and encourage you is that if some of you, for example, 15, 20 years ago did a unit A or a unit 1, whichever one it's going to be, is if there is a kind of, well, what about having a look and refresh you? Maybe there's other options out there. And really, just to be able to come part of it. But as I say, we're going to have a little question and answer session with Neil and yourself. You can have a chat. So just really, this is kind of where it happens really. So I think, was that you, Richard? Yeah. We had those conversations of, let's try and make it into something. So we can thank Richard for the picture, which is that will appear in your nightmares tonight. But yeah, so we'll take any questions and just conversation. Neil. I hope they don't. I've got tickets. So no, I hope they, yeah, absolutely. Well, hopefully we'll stick around longer than that anyway.
So I guess, how did this collaboration come about? What was the kind of history behind it? Well, I guess it's a little bit about, if you take a little bit of a step backwards, and you have to ask yourself, like when I came into the chair role about 3 years ago, what is the point of professional networks? What are we actually here for? Is it self-serving? Is it all about just serving our members? Or is it something bigger? And actually what we've gained from today is the importance of collaboration. And what I certainly saw was an opportunity to challenge philosophical standpoints. So essentially, I remember clicking on my Mulligan belt, ready for action in the mid-90s. I remember all the different courses you could go, and you would store those up and you would become labelled that way. But that's a framework for safety, so you could go with your own tribe. But we've clearly moved on from there. So one of the things I thought is actually we need to be reaching out and working more closely, because essentially it's just a language difference. I work at a university that has chiropractic and osteopathy as well as physiotherapy, and it's a lot of semantics and it's a lot of language differences. So really it came about from just a conversation we had, shared values, shared purpose. One of our aims for the MACP is to lead unified advanced musculoskeletal healthcare, and you cannot do that on your own, you cannot do that in silos. So the whole point is to collaborate and share. We offer a clinical interest group process that Nick and I are working towards and are launching today. This is the whole point of the conversation. Essentially, it's about improving education, improving standards, so we can really push on patient care to the next level that we all want to.
Yeah, I think that's just how it's been. It was just like a kind of an informal conversation at an event such as this, and then it kind of led on from that. And the big point is the fact that, it's that not being in competition. You don't have to do one thing or the other. Understanding that it's about opportunity, and any individual can choose what they want to do, where their education lies, where their pathway takes them. And the fact is that there are, there's no one way to treat any injury. There's always multiple ways, and the more informed you are, the more rounded you have. At certain patients, you use certain tools for your toolkit, and that's really what we wanted to come together to share and be able to be, an opportunity for all, really.
And there's another point. If we were starting from now, we wouldn't have these separate groups. It just wouldn't happen. But you can't get away from the history, and we have to respect that. So you have to say, well, what do we do from now? And that is about collaborating and bringing things together. Because who are our stakeholders? The stakeholders don't really care about that. They're not interested about our philosophical standpoints and how we grew. Well, they're interested about what we do tomorrow. So the only way to do that effectively is actually have conversations, build collaborations, and then you get an effective voice. And then, sadly, we don't always have an effective voice at the right tables, and critical mass is absolutely essential. So the broader and bigger we can do that, the better I think we can achieve things.
Yeah, I think absolutely. The one thing with that is that sometimes what it's about, so it's about influencing change, whether that's policy, whether that's the CSP, whether that's healthcare in general. And the more voices that say it, the louder you can be, the better that's going to be. So that is going to be being together. It still means that the MACP and SOMM, they're still separate organisations, but SOMM's become a clinical interest group within the MACP. So I think it's about understanding that we're recognising each other's identity and what we stand for and the values, but just going actually having that where we can break down some of those historical barriers that neither of us, when we spoke about, really understood why it was like that. But it was just, we can change it, and we can change it just by coming together, having the discussion and opening, so that, for example, if you're going to do a day like this in next year, the advert will be is that SOMM members would come in, you've got MACP members, and then you're just sharing the knowledge and experiences to be able to be better clinicians overall.
Any questions or any points from the group?
Yes, I think it's great. I think there's something that's a bit bigger for me in terms of that influence. Yes, we're both relatively decent-sized organisations, but in the scheme of things, it's tiny. Helen was previously chair of the National MSK Partnership Group. Sharon and myself co-chairing that. I think this collaboration would be great to feed into that, because Sharon and I have got, by dint of being in that position, we've got a seat at the national table and national policy, and that's a really great forum for everybody to feed into, whether it's physios, osteopaths, chiropractors, medics. We've got 47 organisations who feed into that. So for me, it would be great to use this collaboration to have a strong voice, to feed into that group. because it's an easy group for national policymakers to say, where can we get a message out, where can we get feedback. So that would be something I think would be really helpful to kind of build on this collaboration. But I think great for doing it. I think it's exactly the right way to go.
Of course, and from a policy perspective, that's a very small part of what we do. This is primarily about education and practice. So we certainly we do feed in there, and we do sit at that table, and that I can see that is the funnel. But this is about trying to bring educational standards into one house from lots of different sort of funnels in. So we have mapped that work. We want as many folks to be able to use their educational experiences, their CPD, into something unified, so therefore there is a trust that patients and stakeholders can have in terms of how people are educated and how people practice. So that probably is the most underpinning. There's a policy and there's an influence element. The most, I think, primarily this is about collaborative education.
You mentioned, is there anything else in terms of members' benefits, would you say, from this collaboration?
I think primarily it is the educational opportunities, making sure that when you complete something, there is a currency attached to that through the portfolio routes. That's where the conversation started. So the portfolio route sitting there is an opportunity for you to utilise something in a more formal framework. There are obviously mechanisms within education that you can do that, but outside that there isn't anything. And what we have available to us are advanced practice standards that are sitting equivalents underpinned by obviously the IFAR standards. And we have those, and we want to be able to share those as widely as possible, because it's a little pointless having one organisation with small numbers having that. We want to be able to broaden and grow that as much as possible.
Yeah, and I think certainly from SOMM's point of view, as I say, we used to have a master's course which we ran with originally with Middlesex and Queen Margaret's University in Edinburgh, and we were just kind of going, numbers aren't wonderful. We have a lot of people that come through the courses, and then eventually they don't go on and do that. And so really what we were saying is people who have done the courses, either the foundation or the injection therapy, they have master's level credits. What do they do with them? And it seems a logical progression that the MACP is a logical pathway, and then just brings that shared experience together. So, it is about having, if you've done one of the SOMM courses, or particularly if you've done the full foundation, is what can you use that for? Queen Margaret's in Edinburgh still do a master's module that you can take those credits into, but also because it's mapped into this into the portfolio route, it just makes it simple that you can go, actually I can do that, and I only need to top up X and Y, and then I can become a member of the MACP, so you get the benefits of that collective experience.
Good.
Frontline advert was my bad.
Right, I knew someone was going to be able to do that. But the thing with that is that what I would say with that is it just shows that even though we've been around and doing this for a long time, those perceptions of what's always happened from SOMM is always the same thing. So don't worry about that at all. Obviously, the O in SOMM went from orthopaedic and it's now OV. But that's just the way it changed. But it's just the sort of thing is that people often just have that historical, I'm not doing SOMM because I'm an MACP, or the vice versa. And what I'm saying is that both organisations do it. And when you're out in practice, you see what's happened. Why didn't you ever do SOMM? Well, my boss, my supervisor, she always said that I should do these courses. And you go down on a pathway, and when you're newly qualified, you don't really have the opportunity to disagree that many times. And the idea is now, as you go, well, it doesn't matter which way they send you, you've got other options that you can choose.
We're still the manipulation group sometimes, aren't we?
Yeah, exactly. It's that same thing. When did you change your name as manipulation? I can't remember that one.
16?
16. So a similar sort of time to us. We were 2013 that we changed the name. But again, it was orthopaedic or it was manipulation, and now it's musculoskeletal. But again, it does encompass what we're trying to do. And like we say, patients don't care. They just want an appropriately trained clinician treatment, and the rest of it, they don't care what's going on.
Great. Okay.
Brilliant. Thank you. I look forward to developing things. And if there's any questions, feel free to catch us a bit later on.
Thank you.
Thank you.